Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Professor Maria Fiatarone Singh is a geriatrician whose research, clinical, and teaching career has focused on the integration of medicine, exercise physiology, and nutrition as a means to improve health status and quality of life across the lifespan. She has held the inaugural John Sutton Chair of Exercise and Sports Science in the Faculty of Health Sciences and Professorship, Sydney Medical School at the University of Sydney since 1999. Professor Singh has designed and carried out many clinical trials and longitudinal studies in Australia, the United States, and abroad, including large multi-center trials of exercise and chronic disease prevention and treatment. She is a pioneer in several organizations who are investigating contributions to performance, adaptation, and exercise treatment of chronic disease. She has published extensively, and I mean extensively, in the area of health implications of exercise and nutrition, having authored and edited a book, written more than 170 peer-reviewed journal articles, 100 peer-reviewed book chapters, position stands, review articles, and over 400 abstracts. Wow. She is currently supervising 7 postgraduate students and fellows in studies of musculoskeletal, neurological, cardiovascular, and metabolic disease and aging. Dr. Maria Singh, what an absolute honor it is to welcome you to Boundless Body Radio.
Thank you. Nice to be here.
Well, to be here, you had to wake up very, very early. You're on the opposite end of the planet. The only thing really great for you is you've got summer coming as summer is going away from us here in the Northern Hemisphere, which makes me always very sad. But we realize you have to wake up very, very early to do interviews like this. So we're very, very grateful for you. So thank you so very much for getting up early.
My pleasure.
I have been aware of your work for quite a while. People have been talking about it. I know kind of what you've been doing and how this research has been moving along, but it really wasn't until getting introduced to you in particular electronically and then really diving into this topic that I've gotten to know a lot more about your research. And it is absolutely wonderful. It is so amazing to see the things that you've learned and discovered working in a field that I don't think many people would have even tried to touch when you were first starting this. And also to think about like how wonderful your research is and what a difference it could have made had it gotten out to more people or haven't if it could get out to more people now. I see people all the time in their older ages not only dying younger but having very poor quality of life for so long. It's amazing. It's just absolutely throttling to think what this research could do to change the lives of countless people out there. Mind-boggling.
Thank you. I agree.
Well, yeah, I hope so. I'd like to start out by how you got interested in this, because like I said, you've been doing this for a very long time and you started this when I don't know that many people were considering this even as a field.
Right. Well, actually, the reason I became a doctor was during high school. My grandmother, who used to watch Jack LaLanne with me every afternoon when she took care of me and was a kind of a health food nut, unfortunately fell off a ladder and broke her hip. And at the time, there was no geriatric medicine. This was in the 1970s. And she had all of the bad things that happen after you break a hip when medicine isn't very good in terms of, medical complications and malnutrition and strokes and delirium, and ended up in a nursing home tied down with Haldol. I mean, all of the horror stories that you heard about. So at that time, I was going to be a vet, but I decided I needed to become a doctor. And I actually, decided that I wanted to go into aging, which wasn't a specialty at that time. There was no geriatric medicine specialty. So I went to medical school, and I used to tell my medical school friends I was going to start a geriatric sports medicine clinic, but I didn't even really know what that meant. And everyone thought I was kind of crazy. But I had the good fortune of, after my geriatric fellowship, of moving to Boston to do my first job at Tufts and Harvard, and working in a lab that was run by Bill Evans, who's a kind of a very well-known leader in the field of exercise and sarcopenia, which is a term that was coined by the director of that center, Erwin Rosenberg, in 1986, which meant the loss of skeletal muscle with aging, which no one had really thought of as a disease. We'd heard of osteoporosis and osteopenia, but sarcopenia was not a thing until he, who was a nutritionist, was going around the hospital wards, and he would look, open up the rooms and go into the rooms and lift under the sheets, and he'd see these skinny little legs sticking out, but it was something nobody was talking about, this loss of muscle. So that was the lab that I worked in, and we decided to do a study in a nursing home called Hebrew Rehabilitation Center in Boston, where everybody was pretty much in their late 80s and 90s, and we didn't know really what to do. But we decided to use the exact same paradigm that Delorme had coined in 1945 about progressive resistance training when he was treating soldiers who had injuries, and decided that having them lift heavy weights was going to be the best way to rehabilitate them. But no one had really done that in medicine before. And so we decided that these people who could, barely walk around the nursing home, that this was the missing secret ingredient, really, was something to treat their muscle strength. And so we did our first studies back there in 1988 and found that we could markedly increase strength and mobility. And we did muscle biopsies, and we could see that little baby muscle cells were forming in their 96-year-old legs. And something that was heresy at the time. People said you couldn't, have any hyperplasia or new muscle cells after childhood or embryonic life, really. So that was kind of the beginning, and we went from there to lots of other clinical diseases that are associated with this loss of muscle. So things like sarcopenia, as well as osteoporosis, heart disease, diabetes, depression, renal failure, pretty much every chronic disease that you can think about is accompanied by some kind of inflammation that causes you to lose muscle. So very much central to the concept of aging. And so since that time, we've done, lots of clinical trials and also set up clinical programs to try and insert this into the medical mainstream. I would say it isn't yet in the medical mainstream, except in my clinical practice, but it is certainly something that is a missing ingredient for healthcare, I would say, globally.
Wow. Well, you mentioned heresy, and trying to think back on that time in the 80s, the jogging boom had just kind of started maybe the decade earlier. We were well in the throes of the low fat movement and, the no fat kind of area. The food pyramid would have come out a few years later. But I'm just thinking like this must have been very controversial to do that initial study, right?
Yeah, I mean, I think there was a lot of skepticism, mostly I would say on the part of the healthcare practitioners, not so much the patients or the residents. So when we went to this nursing home and tried to promote our study for the first time, and we had like a meeting in a seminar room or auditorium, and people came down to hear because it was a place that lots of research was done affiliated with Harvard, and so they were always used to hearing about new studies that they could participate in. And so I proposed my study, and I said, we're going to do weightlifting, and who wants to join my study? And they kind of looked at me like I was crazy, and I said, well, do you want to live longer? And they looked at me like, we're 90-year-old Holocaust survivors, we're good, and so I said, well, what would make you, want to do this study? And this little man in the front row stood up, and he said, what I would like is I would like to be able to get up in the middle of the night, go to the bathroom by myself without calling the nurse, and come back to my bed. And I said, I can give you that. So that was really the kind of, light bulb moment that, mobility is the key. And, these people don't need to run a marathon. Mostly they need to navigate their, environment around their home and walk to the store and those kinds of things. And the medicines that we give them treat their diseases, but we don't have any medicines for the things that are really core to their quality of life, as you said, which is often frailty, mobility impairment, falls, fear of falling, activity restriction, fatigue. So we don't have drugs for any of those things, right? We have drugs for organs, but not for the thing that is really bothering them. And I'm, as a geriatrician, which is what I am, when people are sent to me for consultation from other doctors, they're very well doctored up with, lots of organ specialists for every part of their body and lots of medications. But I often find that when they walk in the door, no one has really seen them. The thing that strikes me, absolutely first when I see them is this frailty often, but it isn't on their list of diagnoses. It isn't, there's no drug for it. No one has really, called it. And that's what we treat. And we still, we treat their medical diseases because a lot of them contribute to frailty and lots of drug side effects contribute to frailty, but none of them treat it. And so we deliver the treatment, which is high intensity progressive resistance training, often with balance training added. We don't prescribe walking or aerobic exercise initially for most of them. We do later on, but the thing that kind of is very striking is that if you look at a young person who's not walking or running, they don't want to, or they don't have time. They can, but they just don't want to. Whereas an older person who isn't walking, it's not really lack of desire, it's really lack of capacity. So it's very much like a baby almost who, desire is fine. You don't have to pat them on the back and say, oh, really, really should be exercising. You have to give them capacity, which is generally growing up. Whereas in an older adult, it's kind of the same again. They don't not want to walk. It's just that they have lost the reserves that allow them to get out of a chair safely and stand up and walk across the room. And we found that even in that first study we did, we just did seated strength training, no balance training, nothing else. And they began walking around the nursing home 35% more with activity monitors that we put on their ankles compared to the people in the control group who were getting the typical kind of gentle exercise, throwing a beach ball around class in the nursing home. So that's really so we focus on the prime movers, if you will, of mobility, and then often find that other things emanate from that. And it's not just physical. We've done studies with clinical depression and with cognitive impairment and early dementia and late dementia, in fact. And we see very strong neuropsychological changes as well. And it's not, not so much of a mystery because the head is connected to the body, and basically the anabolic factors that, or the, muscle growth factors that emanate when you contract a muscle do go to the brain. And the neurons have the same requirements as muscle cells in terms of liking anabolic hormones and not liking catabolic or destructive hormones or insulin, inflammatory mediators, things like that. So exercise is very anti-inflammatory in that way. It kind of shifts you from this catabolic to an anabolic milieu, which is what you want. And so without, giving somebody testosterone or androgens in any form, you can induce those same anabolic changes with the weightlifting exercise, and sometimes accompanied by, protein and things if they're malnourished. But, that's the key that's missing from the drugs that we give, unfortunately.
Yeah, wow. So I learned that from you very recently. I don't think this can be overstated. In that first study, the group of people that you were doing strength training for, you weren't telling them that they should also go walk or add more movement to their day. They just spontaneously did it because it's that capacity, like you were saying, like the baby. The baby would love to walk around or run around, sees everybody else doing it, just can't do it at that time.
Absolutely,
It needs
100%.
time to build that skill. It's absolutely spontaneous.
Yeah, and if you look at a nursing, I mean, I think the conception of most people is that, walking's the easiest thing to do, right? If you're going to exercise somebody, the safest, easiest thing to do is to just tell them to take a walk, which is what most doctors do. You should be a little more active. Go take a walk. And if you look into a nursing home, most people can't walk or walk very well. They're sitting along the hallways in their wheelchairs. They can barely get up without falling over. So I tried to start a walking group in my second study there, and we couldn't do it. We couldn't find anybody who could, join the walking group, except for pushing somebody else in a wheelchair. And so it became quite obvious that walking is really hard, but sitting on a machine and lifting heavy weights is actually quite easy, quite feasible, quite doable. Almost everybody can do it, almost everyone. And we did a study a little bit later where we went to like 18 different nursing homes and we're comparing different kinds of rehab. And we had one of the arms of the study was weightlifting, and we went to the nurses and we, as a screening thing, we were having the nurses like pick out people who might join the study. And we had this form that we had designed, which was meant to kind of trick them into thinking the way they were taught. And on the front of it were all the different chronic diseases that people might have, and, everything you can think of head to toe. And it said, does your patient have any of these? And it was a little tick box next to each one. And so they ticked off, heart disease, diabetes, lung disease, whatever. And then it said, please turn over. And then, in the back, it said, congratulations, your patient, has 7 diseases that qualify for them for this study, because it's the exact opposite of what people think is that, the more diseases they have, the more it's relevant. And one of the nurses I remember came up to me and she said, she was very timid. She said, I have this patient. I don't know if it would really apply to her. I'm not sure. Can you come and see her? So I went into her room and there was this woman lying in it. She wasn't that old. She was in her 60s, but very, very skeletal sarcopenia, like almost no muscle. And she'd had rheumatoid arthritis her whole life and was kind of lying in bed, contracted. Most of her joints were contracted, cognitively intact. And she had this one arm that moved. She had her left arm, I remember it was, she could, still bend up her elbow and she could, touch her head and things. And the nurse said to me, do you think she would qualify for your program? And I looked at this woman, I said, I've never seen anybody more in need of weightlifting than this woman. I said, she's got one muscle that still moves, her biceps. She has the dignity to feed herself and to comb her hair still with that one arm. And there isn't anybody I can think of who needs it more than her, to try and keep that last sort of shred of dignity. And obviously, there was no other kind of exercise this woman could possibly do, right? And there's no drug to help her. But keeping that one arm moving, by making it stronger and more functional, is the one thing that she had left in terms of her quality of life. So I think, again, it's the exact opposite of what people think in terms of feasibility. The people you think are the least able to do it are really the people least able to do aerobic exercise, but they still can do weightlifting exercise. Absolutely.
That's amazing. What an amazing story. When you see somebody like that, I'm not sure specifically with her case or not. Like when you see somebody that gets that level, can they effectively maintain the strength they have, or are they actually gaining function and able to move, say, like both arms in that situation? Or maybe, they're starting to like, stand up and down or whatever. Like can you recover from that?
Absolutely. I mean, in her case, a little bit different because she had fixed contractures. But if you think of somebody who is just, frail and malnourished and, coming out of the hospital after a long period, who got very, very deconditioned, absolutely, you can make them stronger and able to walk again. And you're not going to make somebody into a 20-year-old athlete, but we have a lot of patients who, have gone from very limited mobility to, being very functional. And we promote, sort of trying to have goals. So, what are you training for? I want to dance at my daughter's wedding. I'm going on a cruise. I don't want to fall over. I want to play golf again. And so, we do get people back to those things. We prehab them a lot for surgery. So if you think about somebody going in for a knee replacement or a hip replacement, they're usually pretty inactive because it's so painful to walk, that they're very, very inactive. And so they get very, very unfit just before their catabolic surgery, right? And then they're supposed to recover from it. So we take that time, and often people are on waiting lists, at least in Australia, probably in America too, for months or even a year for a elective joint replacement. So we use that time to prehab them, and get them as strong as possible. And the doctors, the orthopedic surgeons, love to get our patients, because there's your patients just sail through surgery. They go to the rehab hospitals, and the nurse, the physios are trying to get them to lift little baby weights. And they're like, wait a minute, I've been lifting 100 kilos on the leg press at the gym. What are you doing with this, 1 pound ankle weight around my ankle? And they, but that's what they're used to. They're used to old people, being very weak. And the ones who come from our clinic, and my geriatric medicine practice, I have a large gym essentially. It's right in, my office is in the gym essentially. So all of my patients that I see, go right outside my office and lift weights 2 or 3 days a week forever if we can get them to do it. So we have a very different optimism about what people can recover from, and also prehab for, and rehab from. And things happen. People get strokes and heart attacks and hip fractures, and all things, sorts of things happen along the way. But we always get them back if we can, as soon as possible, and get them back into training again.
Wow, that's amazing. I'm hoping some of your patients are inspiring other people in these, rehab clinics. If somebody's only able to do the ankle weight and they look over and see somebody 10 years older than them just curling like way more weight than them, that's pretty incredible. I want to go back to, again, kind of as you were forming your thinking around this, you're developing that very first study. What was it about you that made you think that this was going to be successful? I assume the same myths were around then that are now. Like you get to a certain age, you can't add muscle. You're not going to get stronger. You're just going to continually lose. Why did you think you were going to be successful with this?
Um, well, I mean, I do think a lot of it came from growing up, like I say, with my grandmother watching Jack LaLanne. I mean, he and his wife were on TV for what, 40 years or something.
Long time.
My dad loved him. My dad was kind of a bodybuilder in his youth, and he always loved Jack LaLanne, would show me the pictures of him, age 70, towing 70 tugboats across from Alcatraz to the shore. And, because every birthday he had these like amazing feats. And so I kind of grew up, with that thought that, aging is not necessarily a time of decrepitude. And both my parents, worked. My dad, worked till he died. My mom's 96. She works full time running a music store in California, 7 days a week, 8 or 9 hours a day at age 96. And she doesn't exercise, but at least, I had this concept that aging wasn't necessarily a time of decline if you didn't, want it to be. And so I think that, and the way that I grew up with my grandmother, I was always very, sort of sporty myself in terms of athletics and things. So I just, yeah, kind of had a different concept about, I was very much into sort of holistic medicine and, wanting to incorporate nutrition and those kinds of things into medical practice. Always very suspicious of drugs and drug companies, and led the medical student revolt, where when Lilly came and gave us all stethoscopes, we immediately took them all down to Mexico. I was in San Diego and gave them to a clinic in Tijuana, and refused to accept any bribes from big pharma. So I was always a bit of a I grew up in Berkeley, basically, so you get the rest. So I always kind of on the front lines, battling, yeah, the government on whatever they were doing that was crazy. So I think I just had a different perspective on what, in fact, I didn't get into medical school. I went to Stanford undergrad and applied to medical schools all over the place. Didn't get in the first year, toured around the country with every medical school I could find. And, for no reason, well, probably good reason, because every interview I went, when they would ask me what I want to do, I would say how awful the medical system was and how money hungry doctors were and everybody should take a salary cut. And so that probably is why I didn't get in the first year. The second year, I only applied to UC San Diego. And weirdly enough, I was just going to join the Peace Corps because I gave up on the medical system. I was like, this is ridiculous. But I said, I'll try one more time. I'll apply to one school. And I don't even know why I picked UC San Diego, but I did. And probably because it was close. And I had no pictures. It was like, no digital stuff at the time. I used one of my mother's school photos as my photo on the application. And so I walked into the room and the interviewer was like, is this you? And I'm like, well, actually, that's my mother. So he probably should have kicked me out then for fraud. But yeah, it turned out he was a fencer and I was a fencer. So we spent the entire interview talking about fencing, and, which sword we were using and whatever. And that's why I got into medical school. So yeah, so this is kind of a weird route, but I mean, basically, I pretty much sort of against the established norms of the medical association. I didn't like the AMA because I thought they were a lobby created to make doctors richer, which probably still true. Maybe not so much anymore. But I always was very suspicious of the amount of drugs that were being promoted, and I spent half my life now stopping drugs that other doctors have started because of side effects and because of particularly things like antidepressants, because we know they don't work really much better than a placebo. Exercise is about twice as effective, and but one of the most prescribed drugs on the planet would be the drugs like Prozac and Zoloft, and lots and lots of drugs like that we really are kind of misusing our knowledge about nutrition and exercise to treat things. Even if you look at diabetes, that one of the largest diabetes prevention study that was ever done, called the Diabetes Prevention Program, the DPP, in the US, 3,500 people, middle-aged, overweight, impaired glucose tolerance. And they were randomized to get either lifestyle, which was joining a YMCA, doing strength training and aerobic training, plus a low-fat, high-fiber diet, versus metformin, which is a drug that's used to prevent diabetes and also to treat it, versus a control group. And it turned out the lifestyle group had like a 60% reduction in the incidence of diabetes in the next 3 years. Metformin worked about half as well, about a 30% reduction. And in the older adults, actually, metformin was no better than the placebo. It was a lifestyle group. So anybody over the age of 60, they did really well. Like they had an 80% reduction in diabetes incidence, being at high risk because they were already, had impaired glucose tolerance. So what do we do from that? Well, Medicare, health insurance, they'll pay for metformin for life to prevent diabetes. But except for the first couple of years when they did it, they won't pay for, gym memberships for life and dietitians for life, even though it's twice as effective. Why is that? Well, because, there's money to be made from the drugs to prevent diabetes, not so much from the lifestyle changes to prevent it. So I think we're massively misreading the literature. Doctors don't, most, well-trained doctors wouldn't be able to tell you those results. They haven't read those studies. They don't. but that is the evidence. So I'm very much, ingrained in the evidence. I don't do anything that isn't evidence-based. Have to prove everything for every disease. I refuse to disseminate stuff for which there is no good evidence. But I think, that isn't the way people practice, and particularly with exercise. I mean, I think because doctors, aren't exposed to it as a drug, they don't treat it like a drug. They don't prescribe it like a drug. They don't follow it like a drug. Whereas that's exactly what we do. And we only prescribe the right type for the right disease, the right dose. We follow it. And that is the problem. It's not central to the practice of medicine. It's peripheral, and they farm it out to, exercise trainers or physios or whoever who aren't really trained in medicine. They don't deliver it themselves. It's not really their fault. They weren't trained in it. I had to go out of my way to train myself about, and I really had I never really did any weightlifting. I did a lot of, fencing. We ran the stadium steps, but we never did formal weightlifting. So I never really heard about it as medicine until I went to Boston. I went to the sarcopenia lab, and Bill Evans was doing all sorts of studies in younger adults on sarcopenia and weightlifting. And I was working at the nursing home. And so we together, we thought, well, all this stuff you're doing, the people who need it most are the people living in this nursing home. Why don't we try it there? So I had the opportunity of working with, the person who invented the term sarcopenia, Dr. Erwin Rosenberg, which, most doctors are not trained in anything related to that, and not in nutrition either. So Erwin he's a nutritionist. And so he also taught me a lot about nutrition, which my grandmother did as well. And so, I had the opportunity to learn things that most doctors, don't, because it's not in their training. But I think the main problem is that we don't think of it as medicine. We don't pay for it like medicine. Insurance companies don't reimburse you most of the time, for the kinds of treatment that is really core to your disease. Because even when we have, good drugs for for diseases like congestive heart failure, we've got great drugs. We've got, everybody with heart failure now is on the sort of four pillars of heart failure treatment. They're all on these four drugs. But we know that if you also exercise, you do even better, because heart failure is an inflammatory disease. There's a lot of muscle wasting. And Andrew Coates, who's a cardiologist, used to say the central role of the periphery. So the peripheral muscles are where the heart is pumping blood to. And if they're wasted away, even if you treat the heart, it can't deliver it to a working muscle bed. And so you have to treat the periphery if you want to, have the central heart working well. So as a geriatrician, everything's connected to everything. When I see somebody, it's, everything's connected to, they're always asking, why are you taking my shoes off? Nobody ever does that. And it's because everything is related to everything, and that's why, unless you're doing a really good history and physical, and assessments, and we spend hours assessing I spend 2 hours with them just doing a history and physical. Then they go to my exercise physiologist, who spent 2 days doing assessments from head to toe. And then we start their exercise program and often add a dietary component. So that isn't what happens. If you get a 10-minute GP visit, there's no way that anybody can really tell what's wrong with you. And that is the problem. And if you actually do go to a exercise person, they're divorced from your medical team, right? The exercise physiologist or even the physical therapist, they're not really treating your medical diseases. They're rehabbing you from a rotator cuff tear or something, but they're not, seeing the whole picture, and they're not your core treatment team, which is why I think what we do is a bit different. Yeah.
It's absolutely fascinating. Boy, I would love to see you time travel back, 40, 50 years to your original self, who distrusted the medical system and everything going on with pharma, to explain how
I
everything
was a
is
radical.
actually
I
in
was
like
a
2025.
radical. Looking
Just
back
wait,
at
in
my interview,
2025, it's not
yeah,
getting better.
if I had recorded those interviews, I would have looked at myself and said, "What are you trying to do? Just get in first and then fight the system." But I was always like, "Fight the man." It's like
Uh,
I grew up
I
in
love
Berkeley.
it.
Buses going through Berkeley to help my high school, and every few days the bus driver would say, "Get on the floor," because tear gas would be flying over
Oh my
the
goodness.
bus. So that was my
Wow.
background.
Well, that's amazing. Yeah, well, things are not better 50 years later. So let me just tell you. Okay, so we've mentioned some of the terms that are related to the strength training that you do. So you mentioned progressive overload. You mentioned high intensity. Most people, I would imagine, when they hear high intensity, are thinking like, oh yeah, like that's the studio down the street. I went and tried that for a week, and they made me jump around and throw things and boxes and try to climb ropes and stuff. And I didn't really like that, and I was sore for a month. Like, what
Right.
is all that? Like, can you tell us a little bit about some of the principles that you apply across the spectrum? What, like you said earlier, the things that work for 20 and 30-year-olds that you were able to then apply to older people as well.
Absolutely. So yeah, so the original treatise on progressive resistance training was written by Delorme in 1945, and he was an orthopedic surgeon working for the Army in Natick, Massachusetts. He was rehabbing soldiers, so he was the first person to write in the medical literature about the kinds of things that weightlifters were doing that obviously was making them stronger. And the principle of progressive resistance training is simply that you lift a weight that feels heavy to lift, and we've kind of operationalized that in a way I'll mention. And then as you get stronger, which happens quite quickly, you increase the weight, so it always feels hard to lift. That's it. So it's progressive overload, and muscle adapts, as he wrote, to an uncustomary force. So unless you've been in outer space for a while and you come back, gravity is not an uncustomary force for your body. It might be if you've been in bed for a while and then you try and get up, but for most of us, who are just walking around on Earth, we're used to gravity. So walking does not make you stronger, which is why this advice to go take a walk, even for women with osteoporosis, which has the same, requirements as muscle does for growth, it doesn't help them. And there are studies showing that if you prescribe a walking program for women with osteoporosis, they actually fall and fracture more than the control group, because you haven't actually given them the resources not to fall, and you also haven't affected their bone. So we basically took those basic principles of muscle growth and also bone growth, which were in the literature for a long time, and said, well, let's just do it that way. So we basically just test how strong somebody is by doing what's called a run repetition maximum, where you lift a progressively heavier weight until you either can't, move it through the full range of motion, or you start to do it in some crazy way. So the last load that you can lift perfectly one time, that's your one repetition maximum. So you can test that in about 10 or 12 reps. You can get to that load if you know what you're doing, and then we just prescribe a percentage of that load to work at. So initially, I didn't know what to do, and I read studies and I saw that people were taking like 6 months to get up to 80% of that peak load, which is considered high intensity. And that didn't seem, particularly interesting or fun for me. So I said, well, let's just do this. This is in our very first nursing home study with 90-year-olds. I said, let's just, test their strength, which we did 2 weeks apart. So we got a good baseline. And then we'll train them 3 days a week, and we'll use 50, 60, 70. And then on day 4, we'll use 80% of the 1RM, because I figured if they can lift 100% of it, they can lift 80% of it, right? Assuming they're doing it in good form. So we did that. And then every day as they lifted it, if it got, a little bit lighter in terms of their perceived exertion, until we retested them, we increased the weight. And we used the Borg scale, which was originally invented by Gunnar Borg for aerobic training, to see what intensity we use. That we modified that to say, okay, if you're between sort of 15 and 18 out of 20 on that scale, that's about 80% of the 1RM, and we proved that. And so we use that little scale in between retesting sessions. And we found that we could rapidly increase from people in that first study, people doubled their muscle strength in 8 weeks. And as soon as we stopped training, they lost about a third of it over the first 4 weeks even. So it doesn't stay around if you don't keep training. And in other studies that we and other people have done, if you do keep progressing the load, people will continue to gain strength over, several years actually. And even if they don't gain, if you're talking about older adults, you lose muscle about 1 to 2% per year with aging if you don't do weightlifting, right? So even if your muscle strength is staying the same, that's not a benefit. That means you have stopped aging, right? Same thing with bone. You lose about 1 to 2% per year. So if your bone density stays the same, you're winning. You have prevented aging of your bone. So I think some people misread it and think, well, it's not going up. We have one woman who's a spokesmodel for a lot of our videos. She's 98 now and 99, I think. When she did these videos with us, we showed these graphs when she was 85 to 96, training 2 or 3 days a week. She actually increased her strength dramatically and was still increasing it at age 96 until COVID hit and the gym closed. And then when we came back, her strength had gone way down. But as soon as she started training again, it came back up. So it's unheard of to, and same thing with her muscle mass, actually. It's unheard of to keep your muscle strength and your muscle mass at age 85 for the next 11 years. Unheard of. No one has ever seen that. And the only thing, and she had many diseases, she had knee replacements, kidney disease, lost one kidney, lung disease, some arthritis, osteoporosis, hypertension. She had all these diseases. So she hadn't aged as a super athlete or in a healthy way. She had just added weightlifting exercise to her chronic disease list, and actually averted, the age-related changes in muscle that would have otherwise occurred. So, we do see that a lot. And so that's basically the idea, is that you lift this weight that feels heavy. We just do like, 2 or 3 sets of 8 repetitions for each muscle group. 2 or 3 days a week. 2 is a little better, little less than 3 probably for bone, but not dramatically different for muscle as long as you're training at a high load. And that's the only thing that you need to think about is, how heavy is it? People want to, obsess for days about, pyramid sets and, random things and undulating loads, and none of that matters. And, how many reps the only thing that matters is, does it feel heavy to lift? That's it. Nothing else matters. Doesn't matter what equipment you use, what, type of, nothing else really matters. And that's the one thing that everybody leaves out. Everything else is fancy up, all these other things that people focus on, and, periodization and cluster sets and this and that and blood flow restricted strength training and blah, blah, blah. None of it matters. The only thing that matters is, does it feel heavy when you pick it up? And that's something you assess. And like, I pick up this cup of coffee. I know it's light, right? First rep, I know it's light. I don't need to use a huge amount of strength or I'll throw it over my head. I know that immediately. My muscles are really good at telling how strong, how heavy something is. So people can do it. People who are blind can do it. People who have dementia can do it. People who have never exercised before can do it. And if they can't, we train our trainers to do what we call an objective board rating. They look at the person and they can tell how heavy it is, right? If you lifted up something right now, I could tell you immediately that's 78% of your 1RM, because I can see what effort you're putting into it. I can look at your face. I can look at your breathing. I can look at your muscle tremor. So I know when it's the right way. I know when it's too heavy. I know when it's too light. And so even if somebody can't tell me, as a good trainer, I can look across the room over the back of my, head and know if it's right. And that's the one thing that is left out of every, older adult exercise class, is the intensity. That's the thing they leave out. You look at all the gentle exercise videos online, all of the PD Warrior visit, online, everything you watch online, the thing they have left out is intensity, and nothing else matters.
That
End of
is tremendous.
Sorry.
Yeah. No, that's so amazing. And yeah, I've been training people for over 18 years now, and I've never been trained in what you're describing, like knowing when that person's on the edge. And instinctively at this point, I know it. I had a client yesterday who
You
was
look
like,
at them in a second, Yeah.
yeah, oh yeah, no, we've done 2 30-minute sessions, and in the second set of the second 30-minute session, I'm like, okay, you're just about there. Next rep, okay, you're done. So it's interesting that you say that, and yeah, the intensity piece being the big missing part, and I can't agree more with you. Like, I don't. It really doesn't matter how you get there. And I tell people, like, we count reps if you want, but reps don't count. How many sets we do, what equipment. If you have a full gym, amazing, use it. If you have a $30 set of bands that you got from Amazon, use that. Like, any of that will work as long as you're getting that intensity level that you're describing.
Absolutely. Absolutely.
Wow,
Yeah.
it's
No, I think,
fascinating.
yeah, for some reason I think there is this fear of intensity. There doesn't seem to be a fear of volume and things, which there probably should be, because that's more likely to cause, exacerbation of underlying arthritis and things. But there's this fear of intensity, which is completely unfounded. And in fact, there's a fear of isometric exercise also, which again is unfounded. Some people can't do dynamic weightlifting because they have severe arthritis in a joint, and so isometric exercise. For example, if you're in a cast, right, you lose a lot of muscle in the arm that or leg that's casted. It's been shown that if you do isometric contractions in that cast where the joint can't move, you can prevent the muscle atrophy of being casted, which is otherwise you take that arm out of the cast, right? It's like this withered little arm. It's only that way because you haven't been doing isometric exercise while you were in that cast, right? So isometric can work. And in fact, with, the fear is that, oh, it'll raise your blood pressure and, people with heart disease can't do it. But the latest meta-analysis from British Journal of Sports Medicine they looked at every systematic review of randomized controlled trial of every kind of exercise for blood pressure. And they found that the kind of exercise that is the most effective for lowering blood pressure is isometric exercise. So wall sits, for example, or even sitting in a chair with a, contracted leg extension, or if you want a hand grip, but wall sits is a more functional way to do it. So we do that in all of our patients now with high blood pressure, which is kind of a, pre-skiing exercise as well, great for the quads, but it actually lowers your blood pressure by 9 or 10 millimeters of mercury, which is more than a
Wow.
drug does. So not only is it not, unsafe for hypertension or cardiac disease, it's actually indicated. And we see a lot of people on 2 or 3 different drugs for high blood pressure now, because it's not well controlled. So we try and add wall sits and then, get rid of at least one of their medications if we can. But cardiologists are still telling people not to lift heavy weights, not to do isometric exercise, and none of it is evidence-based. I mean, all of the randomized controlled trials are published. They're just not reading them. So that's what's annoying is that, like I say, I completely go by the evidence. I won't do anything that's not evidence-based. But the evidence is there. It's not rocket science. The evidence is there. We just have to use it.
Okay, wow, that's amazing. What about the compliance that you see for most people? Obviously, this is going to vary widely, and this is a very general question. But in general, are you finding that people are willing to go through this? Because pushing yourself to those kinds of intensities, that's what I do for my strength training. I don't like it. I would rather go ride my bike and play ice hockey and do all the fun things. I do that because I know that's going to help me with longevity and all the other things that I love to do. So I do
Right.
it not because this is a blast and I'm having such a great time lifting something to that type of intensity. So it's not the most fun, but like, what have you seen as far as compliance goes?
Really, like in our randomized controlled trials, we usually have a very low dropout rate, like, 10% or something, which is considered, very low for a clinical trial. That's a little bit, skewed because only certain people, would sign up for a randomized controlled trial of exercise, although we're very liberal with our inclusion criteria. But, my mom would never exercise. I mean, I don't, there's a lot of people who would never or would never enter a randomized controlled trial, rather. So there's a lot of people who, would not do that. So if you look in our clinical practice, other than a few people, who either completely disinterested or get sick, the compliance again is very high. We have people who've been in our clinical practice since 2015, starting when they're 75 or so, who've been exercising with us for 10 years. And most of them come 2 days a week. And, some of that is financial because they do have to pay for some of this part of the sessions. But even there are ones who've been coming 3 days a week for years. And so we really don't have to, enforce compliance because people like feeling stronger. They like the fact that they feel more functional. They know it's keeping them out of the nursing home. And in fact, we work with a lot of aged care providers who provide home services and the mandate of those, people is to keep people aging in place at home, and they have told me that, they love it when, their clients are coming to Strong, which is the name of our clinic, Center for Strong Medicine, because they are more functional. They do stay at home. They don't go to the nursing home. And one of the studies that we did in honor of my grandmother actually was called Hip Fit, where we took people who'd had a hip fracture, and we looked at the literature and said, well, why do people do so poorly after a hip fracture? 25% of them are dead. 25% are in a nursing home for the first time, a year later. What's going on there? And we looked at the literature, and it turned out there were a whole bunch of things that predict poor outcomes after hip fracture, things like malnutrition and depression and weakness and poor balance and isolation and all of these things. And what we found was that when we look at what people do in a hospital setting for hip fracture is they, you go to an orthopedic surgeon, sometimes a geriatrician as well. They replace your hip or fix it, one or the other. You get a few weeks of physio and then you go home, right? And usually you're discharged from physio when you've gotten back to baseline. That's the mandate of the physiotherapist is you're back to baseline now, so goodbye. So if you think about that, if you get that person back to baseline, the very next day they fell and broke their hip. So how good was that? So we said, well, let's do something different. Let's look at all those risk factors. Let's treat them all because they're all pretty treatable other than age, and follow them for a year and see what happens. So we took these people, 126 people, randomized to usual care, which was that, or our care, which was 13 different interventions, weightlifting, balance training, nutrition assessment, cognitive, so we just basically helped them. Most of it was about the weightlifting and balance training. But if they needed other stuff, we gave it to them, like better nutrition, cognition treatment. And on average, out of those 13 different interventions, people needed 10 of them, which is good. And we knew they needed it by the screening tests we did to get them into it. And so at the end of the year, what we found was that we reduced the chances of going into a nursing home by 85%. And we compared to the control group, who was getting, the best care you can get in Sydney, 12 weeks of physio, orthopedic consult, blah, blah, blah. And we reduced death by a similar amount. And there's this thing in hip fracture literature called poor outcome, which is death or nursing home admission. That's what's called poor outcome. You might wonder why, but it's if you do surveys and you ask women with osteoporosis, if you had a hip fracture, what would you rather have happen after your hip fracture? Would you rather die or go to a nursing home? And they actually say, I would rather be dead than have to go to a nursing home. So that is called poor outcome in all of these trials in the literature. And so we reduced that poor outcome by about 87% compared to usual care, which just means that usual care is completely insufficient. And the reason it's insufficient is it's not addressing sarcopenia and fall risk and mobility impairment and malnutrition and perhaps depression, polypharmacy, cognitive impairment, isolation, all of the things that we know are part of this syndrome we call frailty. So hip fracture is really a frailty manifestation. It's not really about the bone. The bone is just an innocent bystander. The bone breaks because you fell. And you fell because you have no muscle, you have no balance, you have lots of fall risk factors, you're on lots of drugs, you're depressed, you're cognitively impaired, that's why you fell. So if you just put a pin in the bone, or even if you replace the whole hip, you haven't addressed frailty at all, right? So you can do that with a kid who breaks a bone. You fall off a skateboard, you break your wrist, I fix your bone, you're good, right? Because there was nothing wrong with you except you had this risk-taking behavior where you went on a skateboard downhill. But in an older adult who breaks a hip, it's simply just a red flag that, oh, you better look for frailty because that person is very likely to be frail. The only person who wasn't in that study was a youngish man who drank a lot of alcohol, went on a cruise and fell over on the boat and broke his hip. He kind of wasn't frail, but he was the only one who kind of didn't fit the mold. But for the most part, women who break their hips are 85. And unfortunately, the drug study, so people who have osteoporosis, they get put on lots of drugs for their bones. Most of those studies were done on 65-year-old women who fractured their hip or didn't fracture their hip. So if you fracture a hip at 65, you're very unusual, right? That's 20 years too early. So the kinds of women who, the osteoporosis drugs help prevent fractures are not the kind of women I see in clinical practice who, really their bone density is quite low. They just need not to fall, right? I'm not going to make their bone density normal again, whether I give them a drug or whether I give them exercise. I just have to make them not fall. And so I have to deal with all of that other stuff head to toe that is causing them to fall. So that's really what HipFit was about, was treating hip fracture in the way that it should be treated, which is just a frailty syndrome, and not an osteoporosis syndrome. That's the difference, really.
Yeah, that makes so much sense. Wow. Okay. I've been meaning to ask you this as well. I've heard mixed on this, and I'm sure some of your research has probably had some conclusions around this. For example, I've got a guy that I'm training. He's going in for knee replacement next month. He's going to be limited in his lower body. He can still lift weights in his upper body, right? Like he can do a lot of things seated. We can train him at his home versus the gym that we've been training him at. There's lots of things that we can do. Is it more likely that he's going to be able to maintain global musculature, even if he's only locally working the upper body for a little while? I've heard, again, like mixed kind of conclusions around that.
Well, I mean, what I would say, if he's getting one knee replacement, is it? Is he getting a knee?
Yes,
Yeah,
yes.
so if he's getting a knee replacement, I mean, in my experience, a lot of people with bad knee OA can't walk without pain. It's way too painful, but they can certainly sit on a machine still and do particularly open chain exercises like knee extension, maybe limit the range of motion a little bit. And even a leg press, which is a closed chain exercise, they can still often do that even when they can't weight bear. So, and certainly they can do the other three limbs. So we continue to train everything. And even if you did isometric exercise with the bad leg, you can still maintain all of your strength and even gain strength without doing any movement. And it doesn't hurt if you don't move it, right? So there's always a way to do isometric exercise. And basically, you're just thinking, full range of motion is great. If you can't do full, you can, do through the pain-free arc of motion. And the extreme of that is no motion, right? 0 degrees of movement. But it's still high intensity, right? You still have to get that high intensity. You might not be able to go to, this complete degree of flexion or extension that you could, but that's okay. That doesn't matter. We often do isometric training at 3 different angles, at 90, 60, 30, minus 30, so that we get strength throughout those 3 different arcs of motion, or ranges of motion, even if we can't move the joint. So definitely do that. And the other thing you need to do is, once their leg is operated on and it's painful, they're going to be using their arms to get out of a chair, right? Because they need help. So you got to make sure they don't tear their rotator cuff. And you got to make sure their triceps are strong, because otherwise, they will tear their rotator cuff. So we do a lot of triceps training, upper back, external rotation training, to make sure that they're not going to tear their rotator cuff. They can use their triceps to assist. And the other leg is really strong to get weight off the painful leg that's been operated on. So absolutely, prehab is critical. And like I say, our patients for hip and knee replacements, they sail through rehab because of the prehab that they've had. Absolutely.
Amazing. Wow, that's very encouraging. Okay, excellent. I did want to ask you also about nutrition. I would hope that most people who are listening or watching to this know the kind of things we talk about as far as nutrition. What are some of the pillars that people need to know as far as the type of nutrition they need to be doing, even if it's just general principles alongside the strength training?
Right. Well, I mean, I think the myth is that you need like, huge amounts of protein to complement the anabolism of the resistance training. And the data suggests that in young, healthy adults who are, the RDA is, zero point 0.8 grams per kilo per day. That, is the average amount that people need to be in positive nitrogen balance. But as you get older, that amount of protein is insufficient to keep people in positive balance, which is part of why people lose muscle with aging. But in young adults, even if they're healthy, there is evidence to suggest that they eat up to 1.6 grams per kilo per day, so kind of twice, but not the 2 or 3 grams per kilo that sometimes people consume. But 1.6 grams per day gives you about another kilo or kilo and a half of muscle compared to people lifting weights without protein. Protein by itself, doesn't help you very much, and certainly in terms of muscle strength. In older adults, the average sort of gains in muscle with protein increasing above the RDA are zero. Most older adults actually don't benefit from massively increasing their protein intake, like doubling it when they're weightlifting. And the reason for that, in part, is that the weightlifting exercise itself is an anabolic stimulus to the body. So in studies that were done by Bill Evans at Tufts, people who were lifting weights, who were older, were in positive nitrogen balance on 0.8 grams per kilo per day. And when you gave them more protein, they went even more positive. But sedentary older adults were in negative nitrogen balance on 0.8 grams. So the RDA is a bit insufficient. Most people think that older adults probably need closer to 1.2 grams per kilo. But the idea that you need massively more, if you're healthy, is probably not true. And a lot of the studies are a little bit confusing because way that lean body mass is measured is very inaccurate, like DEXA scanning massively overcalls muscle, et cetera. So unless you have biopsy studies, it's hard to really know. So what we do is we look at it clinically. If you're malnourished, you should be fed, right? So and we do a lot of nutritional assessments. So if somebody is not eating enough calories or enough protein or enough micronutrients or enough calcium, whatever it is, we try and get them into good nutritional stead. Not because, not just because it would make their weightlifting better, but because you shouldn't be malnourished, right? So it's a problem you should treat clinically. But we don't typically give supplementation to healthy older adults who are well nourished, who are lifting weights. We do tell them that your needs are probably slightly greater as you get older because the muscle synthesis of protein is a little bit sluggish, and the resorption is a little bit higher. And particularly if they have, chronic diseases that cause inflammation, that is catabolic, that makes you lose skeletal muscle over time. And so you do need to oppose that by making sure that, number one, you're doing an anabolic form of exercise, and number two, you're giving your body, enough protein to meet those needs. And the kind of protein you need is like whey protein that, has the right amino acids in it. So we don't use soy and other non-whey containing proteins because they're not as good, and that's been shown. So we tend to use, if we use a supplement, we use one that is milk-based, or some people like to just take the protein, whey protein itself, and add that to stuff. But we do that, when we have people who are starting out malnourished or sarcopenic, or are going to, go through some kind of an event where they need more protein.
Okay, awesome. The fact about the amount needed for protein was a little bit counterintuitive, and I learned that from you. I found that absolutely interesting, and it's
Yeah.
really helpful because I noticed with a lot of older people, I wouldn't call it an aversion, but it is harder to get more protein in their diet when we're
Yeah, no,
really just
people
trying to
like
get
to
it
eat
sufficient.
carbohydrates, and they, the thing about the, food intake is that, it's very much your appetite is obviously tied to your basal metabolic rate, which is dictated by your muscle mass. So as you lose 40% of your muscle mass from age 20 to 80, which is generally what happens to you, your appetite's going to go down, and so your food intake is going to go down. And when you were eating, this much food, doesn't really matter what you eat, you're going to get everything you need. But if you're eating this much food, it has to be incredibly nutrient dense and dietary diverse. And it's the opposite. People go to tea and toast and high carbohydrate, low protein diets. Maybe somebody's told them to cut out fat. So they're pretty much eating carbohydrate and nothing else, which is not what you need. It's bad for your brain, bad for your diabetes, bad for your muscles. And your body can only absorb so much protein at a time. So if you do need, let's say, 90 grams of protein because you're, 60 kilos, you've got to eat 30, 30, 30 at each meal. Your body can only absorb about 30 grams at a time. So if you try and get all of it at one meal, which is what a lot of people do, they have cereal for breakfast or toast for breakfast and, meat for dinner. But what you really want is, eggs and milk for breakfast, or yogurt and something else for breakfast, and then some protein at lunch as well, and some for dinner, and then high protein snacks like nuts and things, cheese in between the meals. But people tend to do the opposite. They snack on carbohydrates. Because junk food is, going to be high in fat, high in carbohydrates, low in protein. So you got to kind of get rid of prepackaged food and just go for plain nuts of various kinds as a snack, and or peanut butter, if you like that. And then at each meal, try and get, some source of protein. Try and make sure a good portion of it is whey, if you can, in some form, so some kind of dairy product. And, if people are lactose intolerant, you just take a lactate tablet. It's not rocket science. Again, you can drink milk if you, just put the enzyme in it, when you drink it. So a lot of people think they have to completely avoid it, but they don't, right? They just need that enzyme added back. So, we have a bottle of lactate on top of our fridge where we store the up and go drinks, and people who need that. So, yeah. So I think in general, a good diet that's dietary diverse, nutrient dense. We do a lot of Mediterranean-ish type of dietary instruction, lots of extra virgin olive oil, nuts, avocados, lots of vegetables and high fiber, obviously protein, minimal amounts of junk food and that kind of thing. And that kind of a diet, is very healthy for the brain. It's good for diabetes, good for the heart. It's also a good diet for your muscles. So, we don't need to prescribe 20 different kinds of diet. We pretty much prescribe the same, dietary thing. And a lot of people want to lose weight. And unfortunately, if you lose weight by dieting, about 30 or even more percent of that weight is muscle and bone.
For
That's
sure.
the last thing you want, right? So the only way to lose weight by diet is if you're also lifting weights. And there are studies that show this explicitly from, again, the 1980s, Dave Baylor, others, prove this very clearly. Diet, you lose muscle and bone. Diet plus aerobic exercise, you lose muscle and bone. Diet plus weightlifting, you actually gain muscle and bone in the context of losing weight. So that is the only paradigm that works. That's the only paradigm we prescribe for weight loss. Dietitians do not do it. They tell people to lose weight even when they're 80. And worst thing you could do. There's no benefit to mortality to losing weight at 80, none whatsoever. In fact, people who lose weight at 80 have a higher mortality.
Makes
So
sense.
we do it more for joint issues because high obesity relates to knee arthritis, but we never do it without weightlifting exercise. And all the
Wow.
drugs that are out now, the Wegovy and Ozempic, the studies are all coming out now. People are losing massive amounts of muscle and bone on those drugs, massive amounts. And very few people are prescribing weightlifting with Ozempic. It's not happening. There's a couple trials of it now showing that you can prevent. In fact, there's a systematic review now looking at weightlifting plus Ozempic, showing that you can mitigate or prevent the loss of muscle and bone compared to the controls who are losing huge amounts of it in short periods of time. Same thing with bariatric surgery. You lose that much weight, 40% of it is muscle and bone. So, that you don't want to do.
For sure. Wow. Yeah. I mean, as I look through all of my personal training certifications, there's not one line anywhere in any of them that says you can lose fat and gain muscle at the same time. And I observe it all the time, regardless of what we're using to measure. Obviously, accuracy can be a little bit questionable, but that direction I see all the time where people can lose fat and add muscle at the same time if they're doing the right things, addressing their diet, and only through strength training. I never say it through cardio or anything else. It's
Absolutely.
absolutely
And cardio
fascinating.
does not prevent the muscle loss. Absolutely not. And I mean, there's good studies epidemiologically from Klitgaard in Denmark in 1980 as 88 as well, where he looked at people who were sedentary older men, 70-year-old older men who were weightlifting, running, swimming, or sedentary, which is hard to find in Denmark, but they did find some. And they did everything about the muscle, electromyography, biopsies, et cetera. And the 70-year-old men who were just recreationally, exercising, they weren't elite athletes, they had exactly the same muscle as 20-year-old men. Same size, same muscle fibers, same strength, same EMG characteristics. So they didn't look like 20-year-old bodybuilders. They looked like 20-year-old healthy men, right? And they were weightlifting for, on average about 17 years recreationally. Whereas the aerobic exercisers, they looked exactly like the sedentary men. The aerobic exercise, even over 17 years of aerobically swimming or running, even, they muscle went down exactly as though they were not exercising at all. So that's phenomenal, right? To know that. And so this myth that, that's the most sort of medically sanctioned kind of exercise, aerobic exercise, the Cooper Clinic, it was kind of a, very, what's the word? Zealous sort of approach to exercise where, people were crazy with aerobics classes and, missed the point of aging and all the stuff we know about aging, which was in the literature at the time, actually. It had already been there in terms of muscle and bone. But the myth that, that's the healthy kind of exercise and the rest is for the gym junkies who are kind of narcissists anyway, and who cares what they're doing. And, that idea that it isn't medicine, is so opposite from the truth of what we see.
That's incredible. Incredible. I could talk to you for hours and hours and hours. This is so fascinating to me. I want to be respectful of your time. Thank you for this conversation. This is wonderful research that you've done. And like I said, the number of lives that could have been changed and can still be changed with this information is absolutely stunning. And to think that, yeah, like what you said earlier, there's all these industries that are making money won't make money on this, yet this could really change lives in such a more meaningful way is absolutely staggering. So
That's
again,
what my
thank you so much.
grandmother and Jacqueline.
Yes, exactly. They're wonderful. We love them. Um, Yeah. Anyway, thank you so very much for stopping by today. We really appreciate you. Where can people go to find you and connect with you and your work?
Well, my name's pretty easy to spot. It's pretty unique. So if you look at my name, or you'll see like a website, University of Sydney. But we also have my clinical practice called the Center for Strong Medicine, which you can Google. And there's a lot of information that we're putting on there in terms of how to do this yourself, and articles we've written, and educational videos, and actual videos of how to do strength training. So it's all free. And yeah, we're just getting the website kind of revved up now. But if you Google my name, you'll find both of those things. So that's probably the way to do it. Yeah.
Well, yeah, we will link those in the show notes. You do put out a lot of amazing content that's really helpful and useful. And if nothing else, your clinic looks so awesome with your little office, and then the rest of it is like the fitness floor. It's amazing. It's pretty cool.
Right. Clinical
Yeah, like
geriatric medicine office. Yep.
I love it. I love it. It's awesome. Well, thank you again so very much for all of your amazing work, and thank you for taking time out of your very early day to be on our show today. We really, really appreciate you.
My pleasure. Thank you for having me.
Thank you so much. And this has been another episode of Boundless Body Radio.